I think we'll go ahead and get started. If you could grab some food and get a seat. I'm Ned Vasquez. I'm the program director for the Family Medicine Residency Program of Western Montana. And I've repeatedly told my residents that it's not professional to not start on time, so we're going to start on time. It's my pleasure this morning to welcome you to the first of the Friday morning medical conferences sponsored by the Western Montana Area Health Education Center. As you may or may not appreciate, this conference is beamed to other places, so there are other people listening in. It's my pleasure this morning to introduce Blair Davison. Most of you know Blair as a Providence psychiatrist. You may or may not know that Blair was a WWAMI medical student, so she went to medical school at the University of Washington. She then matriculated at Brown University in Rhode Island, where she completed residency training in pediatrics, psychiatry, and child and adolescent psychiatry. And she's going to talk to us this morning about suicide prevention. I should also mention that if you have questions at the end, we should use this microphone so that the people who are tuning in remotely can hear us. Thanks.
Good morning. Thanks for coming, and it's good to have Friday Medical Conference back up for the academic season. So today the topic I'm talking about, suicide, is a huge one, and there are many considerations, and I want to make sure I leave time for questions, and I also just want to be very clear that I'm not attempting to cover all the very important considerations and factors and dynamics, but to just give a really basic overview of some facts about suicide in the U.S. and in particular suicide in Montana. And I hope that when you leave that we will have met some of these objectives. Most particularly, I want everyone to know that a huge part of prevention is asking the question, are you suicidal? So, but as I mentioned, learn the basic epidemiological facts about suicide in the U.S. and in Montana, review risk factors for suicide, review the importance of screening and tools for screening for suicide, and operationalize an understanding of means matter, and identify at least one phrase for inquiring about suicidal thoughts. So we're going to have a little pre-presentation quiz. Okay. Nationally, suicide accounts for more deaths than homicide. Show of hands for true. Oh my goodness, I may not need to go further. But yes, that is true. So in 2014, suicide was in the United States the number 10 reason for death, with almost 43,000 individuals dying by suicide. Homicide was number 17. Number 1, I'll say it together, heart disease. Close second is cancer at almost 600,000 people. So next question. Firearms are the most common means of completion of suicide. Show of hands for true. Okay, so absolutely true. And I guess the other question to think about here is, are we okay with easy access to killing people? And in the United States, conversations about gun safety are so often very polarized. And that's not my intent this morning. In this presentation, we'll be talking about the facts related to gun safety and suicide, and facts are facts. So we do need to have this discussion. You know, in preparing for this talk, I had to revisit some pretty infamous suicides. Those would be ones involved in Columbine and Sandy Hook, and those involve guns as well. And then we also are just inundated. And as I was thinking about this more, I went back, and because one of the things that was, I was starting right before my senior year in high school, when there was a massacre at a McDonald's in California. And I had to go back and kind of see when that was to make sure I was right about it. And so I just want to raise our consciousness about the relationship of these issues. So, last question in the quiz. Asking someone about being suicidal puts the thought in his or her head. True or false? Right. Absolutely. Assessing is so important. So providers and physicians, we ask about a lot of things. And I think the hesitancy not to ask about suicide and suicidal thoughts is because sometimes we don't know what to do when we get our answer, right? So we know what to do if someone says, oh yes, I do have blood in my stool. We know how we need to proceed, but we don't always know what to do if someone says, yes, I am feeling suicidal. So disclosures, financial, no disclosures, no other relationships than my employment. Biases, yes, of course, we all have those, and mine specifically is mental health. If you have been around me when I've gone off on this, I'm going to limit my comments here, but this is a really artificial distinction. Health is health, and I think what is so bad about this distinction is that it perpetuates a stigma and it perpetuates shame, and those two things, stigma and shame, really do nothing to move forward towards health and well-being. So last time I checked, my head was still attached to my body, and we need to change how we talk about these things. In fact, even when you go to look for statistics about suicide in Montana, it's just this very much segregated, and we learned a long time ago in this country that separate is not equal. So on with the presentation. Suicide in the U.S. So the best data we have, most recent data we have, comes from 2014. And nationally, there were 42,773 deaths from suicide. As I said, that puts it at number 10 in all-cause death in the United States. The majority of those were male, overwhelmingly so, at 33,000. Also, the majority were white Americans at 38, almost 39,000. And 16,294 were men between the ages of 45 and 64. And essentially half were completed with firearms. And then that was followed by suffocation. Specifically, that's typically hanging. And then 6,800 by poisoning. So how's this compare to other countries? The U.S., surprisingly, is 50th in the world because the overall rate in the U.S. is 12.1, so 12 individuals per 100,000 individuals in the United States. Just to look at our neighbor in Canada, their rate is 9.8 individuals per 100,000, and in the United Kingdom, it's 6.2 individuals per 100,000, so about half of what we have. Since 2000, the rate of suicide in the U.S. has increased 28%. That's a public health emergency. The highest rates are among white males age 45 and above. This has been a pretty standard epidemiological fact really since World War II. I don't know, probably before that as well, I would imagine. And the very highest rates among white males age 85 and older. This is so distressing, and I think a lot of people at first glance think, oh, there must be another part of this story. Perhaps those individuals know they're dying and don't want to face. Actually, when you drill down into the data, in our oldest victims of suicide, it's not so much an imminent new diagnosis, life-limiting diagnosis. Chronic pain is certainly something to consider, but it's about social isolation and the sense of becoming a burden to others. So in terms of attempts, over 1 million attempts annually, and females attempt much more frequently than males attempt. So the important thing to take away is that females attempt, but men complete. So it's about 3-to-1 ratio female to male for attempts. And I'll say more about suicide survivors in a little bit. In the Intermountain states, we have the highest rates of suicide. Montana is ranked #1 with a rate of 24.5 individuals per 100,000 individuals. So just to give a little comparison, that's obviously double the national rate of 12 per 100,000. It's also close to the national rate in Kazakhstan, which is #9 in the world for rates of suicide. And we're higher here in Montana than Uganda, just to kind of contextualize it globally. So let me show you a map. This is from a little bit earlier data. But as you can see, this red indicates the highest rates. And I'll say a little bit more about what's some of the thoughts there. Obviously, these are the least populated states. They're also, the altitude in some of those states is higher, and that's been a factor identified as an independent risk factor. So what about here in Montana? So suicide in Montana, for all age groups, for data collected in 2014, Montana has the highest suicide rates in the United States. So this is from the youngest, which is a pediatric issue, to the oldest individuals. We are at the top. Montana has been in the top 5 states for the last 4 decades. So again, this is a problem that persists. For 2014 and 2015, the highest rate of suicide in Montana is among Native Americans, with a staggering rate of 35.5 suicides per 100,000 individuals. This really puts that rate globally among the highest. And whites follow with a rate of 28.1 suicides per 100,000 individuals. Again, highest in the world. And 2 to 3 times the national rates. So what are we doing about it? And I'm quite pleased to say that there have been a decade-long initiative. So some of you may have already seen this, and lots of my information today is taken from this. You can easily access it on the Department of Public Health and Human Services website, which I've listed that address. But this is the Montana Strategic Suicide Prevention Plan. And the most recently updated data was released in July of this year. The current plan is the 7th revision. And the history of this is back in 2000, the Montana Department of Public Health and Human Services organized an initiative to develop statewide plan for suicide prevention. Now this also came out of a national initiative to start identifying risk factors and prevention strategies. So part of this includes the establishment of the Montana Suicide Mortality Review Team. I'm not on this team, but I know individuals on the team. It was established through House Bill 583 during the 2013 legislative session, and it was tasked with identifying factors associated with suicide with the goal to develop prevention strategies, right? We can't have good prevention if we don't understand the dynamics behind the event. And members include representation from mental health field, there we go, social services, law enforcement, coroners, and other experts. And they have compiled a lot of excellent data. So they've actually looked at every, suicide that they have that can have information on that's occurred. And so what are they identifying? So, and again, there are some limitations to how we learn about this because there's some suicides that probably go unaccounted for statistically. By that I mean, you know, this is also the land of single vehicle motor vehicle accidents. And so we have to give to considerations that the numbers are probably, if anything, artificially low, not artificially high. So in Montana, challenges. Some lack of statewide coordination. This is about healthcare. This is about law enforcement. This is about prevention. It's a big place. We can't always all be communicating. And then Montana demographics and geography. I was just talking to someone on the phone from the East Coast, and I mentioned something about going out to dinner with someone and that I was going to be driving 120 miles, and they're like, what? And I'm like, oh, that's nothing. So, you know, it's far between places here. And obviously the lack of mental health providers and treatment facilities. I'm using the language, I don't like it, but it's the language we've got. So specifically, we don't do a great job screening for psychiatric illness and suicide. There's a definite stigma towards seeking care. There's a high availability of firearms. There are high rates of alcohol consumption and this issue of high altitude. So this is kind of an interesting issue. High altitude seems to be an independent factor in suicide. And there are also thoughts about sunshine and vitamin D. And you know, this week has been fabulous. Every time I open up the Missoulian, it's like, woo, some other initiative or topic. And there was, I think, in Tuesday's Missoulian, something about vitamin D supplementation as being beneficial. And so, you know, there are lots of interesting independent risk factors. And what I need to inquire about is whether the high altitude thing pans out globally. I'm not sure if it does. Just a quick look at the lists. Well, I'm not an expert in geography, so I won't make any comments there, but that'd be interesting to see. Okay, so suicide in Montana. I want to talk a little bit about the identification of special populations. Again, as I was saying, we could spend a whole day talking about these things, and I don't mean to, by not talking in more detail, in any way imply that it's not valuable and important to be talking about these things, but I had to limit the scope. But I do have to say that obviously Native Americans at 35.5 individuals per 100,000, we need to be working with our Native American communities and nations to better understand how we can help support prevention efforts in those nations. Veterans represent a special population. You know, there is a lot of conflicting data about the rates of suicide in veteran populations. But Montana, we have a wonderful tradition of serving in the armed forces, so we have a higher per capita rate of individuals who serve. Therefore, we have more per capita veterans. And I think I'll take comments at the end if that's okay. So gay, lesbian, transgendered individuals also have specific issues related to prevention and rates. Incarcerated adults and teens. This is definitely a vulnerable population. And suicide survivors. So now what do I mean by suicide survivors? Well, those are both individuals who've attempted a suicide, obviously, but those are the many individuals who've been affected by a suicide, a completed suicide. So the loved ones, families, friends. This gets a little bit towards the issue of contagion that sometimes is discussed. There are certain pocket communities where there are multiple suicides clustered in a short period of time. So again, all of these special populations, as I'm referring to them, have specific risk factors, specific context. So the prevention may look very different, but the critical thing is assessment is the same. So it's important to remember that each individual is just that, an individual with a very specific context, but the tools that we can use to assess can be generalizable. Doesn't mean that we don't want to pay attention to cultural sensitivity or relevance, but assessment, asking the question, is generalizable. So when do Montanans commit suicide? Well, we're in a typically spike period right now. Highest rates or incidents in January, August, and September. This has been a trend for, this is data from 2014, 2015. We know nationally rates in January are typically high. Lowest rates, February, December. Again, these are just some trends. Something to think about. So the red line where it says even distribution between the months, that doesn't happen, obviously. That's just a theoretical what it would look like. So how do Montanans kill themselves? And it's handguns. And so again, I just want to say this is not bias. This is fact. This is overwhelmingly how Montanans are successful. So let's look at means in Montana. So hopefully these are big enough to be relevant. So of all causes, firearms are 63%. Other causes reflect national trends, suffocation or hanging, poisoning or overdose. Then there's sharp object, jumping, and other means. So as I said, firearms 63%. Of that, handguns are 89%. So what's this mean in terms of firearm deaths in Montana? So obviously we have some homicides, we have some accidental shootings, but that's small potatoes compared to the suicides. So for this 4-year cluster, 106 total firearm deaths from other causes, 745 deaths from suicide from firearms. Pretty staggering. So what can be done? What are warning signs, and how often are there warning signs? So Montana suicides with identified warning signs. Now this is obviously retrospective data, right? Suicide is 100% preventable, but we need to get there. So the majority of individuals who are successful in their suicide have had warning signs in retrospect. And of course this is tragic. It's a tragic public health to think about this, that here we have this opportunity to intervene. So what are the risk factors? What do we do? This comes from the National Strategy of Suicide Prevention back in 2001. So Lots of risk factors. Psychiatric illness is obviously a risk factor. Mood disorders, meaning depression or a bipolar mood disorder, anxiety disorders. Now, this is kind of drilling down, but in 2001, we didn't have the DSM-5, so PTSD was still considered an anxiety disorder in the interesting ways in which my specialty has fluidity. PTSD is now a standalone category of disorders, which I think is important, but I think it used to be clumped as an anxiety disorder. So I just wanted to clarify that point for those of you who were wondering. Thought disorders, by that I mean disorders like schizophrenia where there may be psychosis present. Obviously drug use, hopelessness, and I'm going to say more about drug use, impulsiveness, aggressiveness, history of trauma or abuse. I think most people in healthcare have an understanding about the importance of identifying adverse childhood experiences. That's the acronym ACE. Bullying would be included in that kind of abuse. History of suicide attempt, family history of suicide. Losses, so job loss, financial loss, loss of a relationship, loss of a spouse, loss of a child. And then, of course, access to lethal means. You can't kill yourself if you don't have anything available to do it. Lack of social support, sense of isolation, stigma associated with seeking help, barriers to health care, including lack of availability of health care. So two things that I really want to drill down on are alcohol consumption and individuals who experience chronic pain. So these are definitely risk factors for suicide. And a graph I didn't include, a large percentage of successful suicides that on pathology there is an elevated blood alcohol level. So alcohol is disinhibiting. People do things when they've been drinking alcohol that they wouldn't otherwise do. And this is, in Montana, part, unfortunately, of our culture. In fact, I had a patient one time say to me, it was so memorable, individual had moved here from a different part of the United States and said, used to be that when I lived in Minnesota and people would come over for a party, they'd bring like a 6-pack or maybe a bottle of wine or something, and at the end of the night I'd have like 2 beers left and half a bottle of wine. Well, when I have a party here, everybody brings a case and a couple bottles of wine, and in the morning I just have a bunch of empty cans. And so it is staggering how normalized it is here to drink a lot. So that's a risk factor. The other thing about medical illness as a comorbidity, general medical illness and chronic pain, we know those to be problems. We know we have problems with accidental overdose for individuals with chronic pain. We have multiple problems related to safe prescribing practices, diversion. So I just want to make mention of those because when you look at completed suicides, lots of individuals on their pathology have, could be prescription substances, but combination of opiates and alcohol. So what can be done about this? Protective factors. So these are national factors, but they really do generalize well across communities and come from the National Strategy of Suicide Prevention. So availability of health care, restrictions on lethal means, safe and supportive school and community environments, supportive relationships with healthcare providers, connectedness, so to individuals, to families, to communities, reasons for living. and helping to identify those for individuals. Moral objections to suicide, faith communities can really help in this way. Pets, I have to say that, you know, again, anecdotally, but I have had lots of individuals, and obviously I'm seeing a different subset of the population, but who really have had chronic daily suicidal thoughts, but would never act on those because of their beloved pet. So coping or problem-solving skills. And this again, you know, if your coping mechanism is having a shot of Jack and a six-pack, that's not quite the protective factor we're looking for. So the next slide is going to be a pretty busy slide, and I don't know how well it translates. Not super well. Sorry about this. This is a slide from the CDC. And what I like about it and what you can take home, even though you can't read all the little boxes, is that relationship between the individual and the community, and how important that is both in the protective factors and in the risk factors. So a well-integrated individual into a community is just by definition at less risk than someone who's isolated and alone. And then I just want to share with you my thought about a big risk factor for suicide, and that is shame. So shame, I would say, in all areas of health, is an obstacle to health and well-being. Brene Brown is super popular these days. Oprah can do amazing things. And that's not to take away from Brene Brown. She has some good thoughts. But so shame derives its power from being unspeakable. And this is really true. When individuals feel as if they can't even talk about what's going on is when they've moved that much further away, that much further into their isolation. And shame is a soul-eating emotion. And I just want to say a little bit more about this, because shame is different than guilt or regret. This doesn't sound like I'm full of loving kindness, but guilt and regret actually can be pretty powerful tools for change. We can help individuals to leverage their regrets or their guilt about past actions to help them change their behavior. We can provide them with positive reinforcement about their changes. I would argue that shame does nothing good. It serves to undermine individuals. It serves to undermine communities. It becomes the unspeakable, and really that's where people, I think, get into a lot of trouble, because, and this is from a wonderful individual, Fred Rogers, the man with the red sweater. So, and I truly believe this. Anything that's human is mentionable, and anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. The people we trust with that important talk can help us know that we are not alone. And I think this really speaks to the power of assessing. And this goes not just for anything. This goes, I mean, we have a national epidemic of obesity, and the shame that's associated with things like binge eating. You know, we just have to start having some of these really difficult conversations. So nationally, 45% of people who die by suicide saw a primary care provider within a month of suicide. And of those, 20% saw their primary care provider within 24 hours of suicide. 73% of those age over 65 who died by suicide saw their primary care provider within a month of suicide. So that, you know, again, retrospective data just helps guide us forward. And so what goes into assessing? I'm saying ask the question. Well, we know that there's an association between depression and suicide. So one thing is screening for depression. And in our organization, Providence, this is something that is mandatory and with good reason. And I gotta say, it's easy. I mean, we're all burdened with lots of things we need to be doing, should be doing, want to be doing. But this is a pretty straightforward tool. Some of them are in the back, how the actual tool, how to score them, what it means. It really is easy. I mean, you need to be functionally literate, but it's an easy way. And we know that part of depression can be thoughts of death and suicide. And, you know, in some ways, suicide is very normative. I mean, I would say that anyone who says, I've never thought of it, well, maybe you've never thought of it yourself, but definitely once you've learned the concept, you've thought of it. So, you know, it's not an abnormal thought. So there's the PHQ-9 is in the back, and I'll say a little bit more about that. So how to ask. So what do you do as a healthcare provider, or in almost every profession or work? We ask questions. We ask lots of questions. We ask questions about all sorts of things as healthcare providers that are pretty privileged. Like, I mean, if we're comfortable asking people how many sexual partners they've had, seriously, can we not ask them, you know, about this? And so, again, I go back to the fact that we ask questions because we know what to do with the answers, and I think we get nervous about questions that we want to ask that we don't know what we're going to do with the answer. So just do it. But that's easily said, right? So I want to give you some tools for that. So how to ask. Well, I think this is, you know, just some, I just threw out some, have you thought about ending your life? What would keep you from taking your own life? Sometimes that sounds overly harsh, but for me, that can be a really good determinant. Like, and obviously you want to have kindness and empathy, and you want to have some kind of relationship, but you don't need to have a long-standing relationship. I've asked this question in the ER to complete strangers. And in fact, I would argue that sometimes long-standing relationships, it can make the conversation feel harder because you don't want to be insulting the person, but it's not about that. I would say normalizing the question you're about to ask, saying, you know, it's not uncommon when people are in this situation to feel this way, so that you normalize that experience for individuals. You break down that shame or sense of stigma. And practice asking the question, right? None of us have good skills if we don't practice. And then really important to all of this is also asking the question about means. So do you have access to firearms? So what to do? So assessing risk. Is there a specific plan? Again, you just ask. You just ask in the same caring way you would ask about any symptom. You ask yourself, is the person discussing this in a straightforward way, or are they evasive, dismissive, secretive? Kind of get a sense of if the thought feels good to them or if it feels intrusive and unpleasant. Again, are they open or not? And then once you have a sense of these things, you can start to make a plan. And I also brought along some safety plans. And these are pretty straightforward and simple, and don't take a large amount of time to develop. This does involve some time, but generally when you look at studies on this, it's about 30 minutes for a really good development of a safety plan. So we have some of those in the back. And you want to set specific and concrete strategies. So who to call, where to call, what to do. Then you want to seek support from others. So get permission to talk to other individuals. And in the worst case situation, or when someone is evasive, We do have the help of law enforcement to do safety checks, and the role of the safety check is, we have a responsibility as providers to make sure we're ensuring the safety of those individuals we think at risk. And don't ignore your intuition. Follow up, contact people. I know people get very worried about HIPAA, but when you think there's an imminent risk of harm to life, this isn't about privacy, disruption of patient privacy. So again, the safety plan is in the back, the PHQ-9 is in the back. There's also the CSSRS, is the Columbia Suicide Severity Rating Scale. That can help to determine, where are their thoughts of suicide in terms of severity and imminent risk. And then I also want to share with you the Providence Medical Group algorithm. So I'm sorry, this slide is pretty challenging. We are going to be doing, obviously, trainings on this specifically, but I just want to let individuals who are both in Providence and outside of the Providence organization know that there is a very straightforward and, to the extent that any of this is easy, and I would argue it is pretty easy, this algorithm. So it involves administering the PHQ-9, discussing that with the patient, seeing if there's an imminent plan risk, and then moving from there, providing the patient and the providers with tools. So how to access psychiatric services, the number to call, what to do to get the patient safely from the point of contact to the secure environment. And we can also make those available to anyone who's interested. Just stop by and talk with me after, please. So the other thing to share is the Suicide Prevention Lifeline. It's very useful, national, and 24 hours a day, 7 days a week. It's on the safety plan. It can be for anyone. It can be for someone who's concerned about someone else to get some guidance about what to do. And then here in Montana, we actually have a great new resource, which is you can text MT, the letters MT, to 741-741. And that is another way. I know I myself, I don't know what I did before texting. Texting is fabulous. Holy smokes. So this is a great resource for across all age groups, but obviously all those folks who like to Snapchat, So then, again, I'm going to really conclude about assessing for means. So means matter. We need to assess for means to harm. After we've assessed for just thoughts, we need to assess for means. So many suicide attempts, and this is some of the tragedy, particularly in the context of alcohol use and both prescribed and illicit substance use. So many suicide attempts occur with little planning during a short-term crisis. So, it's the horrible permanent solution to a temporary problem. Intent isn't all that determines whether an attempter lives or dies. 90% of attempters who survive do not go on to die by suicide later. Access to firearms is a risk factor, as I've said multiple times. Firearms used in youth suicide usually belong to a parent, and reducing access to lethal means saves lives. And these are facts. So how does this relate to gun control? This is the verbiage of the Second Amendment, which I think is important to revisit. You can't live in Montana and not have some love or respect for the outdoors and have I gone shooting for pheasants? Have I carried a shotgun? Yes, absolutely. But handguns are a different matter. And so I would argue that these are not infringement. And we actually have some gun locks provided by Providence St. Patrick, so they're in the back. And please, if you need one, please take one. They're easy to use and they work. So the consequence of ignoring the facts are pretty brutal. But remember, 100% preventable. What else in medicine do we have that's 100% preventable? And again, the man in the red sweater, in times of stress, the best thing we can do for each other is to listen with our hearts and to be assured that our questions are just as important as our answers. So I will take some questions. And we will use the microphone so that others who are remote can hear us.
I just heard this week that 8 suicides per day among veterans in the United States.
So that, yes, it's a number that's been anywhere from that to up to 20. I mean, the veteran population has some very particular risk factors, and protective factors look very different, and there are national initiatives specifically addressing prevention and intervention for veterans. And as I mentioned, because so many Montanans serve, it then puts us in a higher place with that population.
Do you have data differentiation between male and female suicide by firearm?
It's actually pretty consistent. Yeah.
So equally male or female on using firearm
well,
for suicide?
There are some, in attempts, there are some differences, but by and large, successful completion, the means are pretty much gender equal. So women kill themselves with guns.
Do these national suicide statistics include patients who choose to die with dignity in those states it's legal?
That's an excellent question. I think that looks very different on a death certificate. I don't think that's listed as suicide. And this is one of the issues, but since that's a relatively, I don't think that accounts for the 28% because I'm almost positive that those individuals are not included in this kind of statistic. The CDC runs a tight ship in terms of cause of death.
So Dr. Davison, you'd mentioned that there'd been a bunch of events this week around this issue, and I hope you'll indulge me. I'm just going to announce another one tonight.
Excellent.
Thank you. So tonight there's going to be a play. It's called The Sun as My Witness. It was written and will be performed by Kevin Kicking Woman. It will be at the Salvation Army Performance Space on Russell at 7 o'clock, and then it'll be followed by a panel. There will be 2 people on the panel who work with suicide prevention in children in the Native community. So hope you would all come, and I'll just leave some flyers up here. It gives you a little bit more information. Thank you.
Blair, comments on suicide rates in healthcare professionals?
Yeah. Pretty staggering. The people who are at most risk, it looks different than national. So the healthcare professionals who are at most risk in terms of physicians are early in practice female physicians. highest among female surgeons. And we're talking either in the last part of residency or the first part of their professional career. Rates are, the rates look actually pretty similar for area of practice. So your geography kind of determines some of that. But obviously physicians tend to be completers, not attempters. So pretty significant concern. And I'm actually, that's something I've spoken on before. There are certain specialties that are at higher risk, certain times in your career that people are at higher risk. I'm sorry I don't have more specific data on other allied health professions. Yes. Oh, hang on for the microphone.
So thank you. That was very interesting and very informative. So if you have information, are there data that suggests you restrict one methodology for committing suicide? So firearms, you restrict firearms. How many go on to use another method?
Method, right. So that's a good question. Obviously when people are suffering and suicide seems like the answer, they're going to look for the means. There's a part of Micronesia in which hanging is the preferred method, and individuals will actually hang themselves from like 18 inches, which when you think about that, that's a very volitional kind of suffocation. So you do bring up a good point. The one thing about limiting, firearms are so flippin' effective. You don't get many second chances. And I'm not saying that anoxic brain injuries don't have consequences, but hanging and overdose or poisoning, jumping, those require a different set of circumstances to be successful. The lethality of firearms is that they're fast and they're lethal. You know, it's just, and yeah, and the impulsivity. You have to plan out, you have to acquire, you have to do a lot of other things. If you've got an unlocked gun in your parents' nightstand, it's there. So I can't say that if we eradicated all handguns, we wouldn't have suicide. I'm not saying that, but I'm just saying it's harder. And one of the reasons I used Canada and the UK is because obviously they have lower rates, in part because access to handguns is a very different equation.
Thank you so much for that presentation. It was wonderful. I would love for you to give this every day in different parts of the county. I'm the suicide prevention coordinator for the Missoula City County Public Health Department. You mentioned the mortality review team. Mm-hmm. And obviously they need to be very private because mm-hmm. they're looking at death reports. But I wonder, do you have a sense for how those are used besides in the state report that comes out once a year? Are they, is there a way that they could be used more widely, yeah. From a physician's perspective?
Yeah. So I downloaded, I recycled, but I downloaded the Strategic Suicide Prevention Plan, which is on the Department of Public Health and Human Services website, but it also has the full report of the Suicide Prevention Task Force is included with all the information because yes, they do have to be private. The other thing that's really important, and I feel like in terms of our whole focus on evidence and evidence-based, Montana is small, and so a lot of these instances are very small n, meaning there were only 8 individuals, and so you can't draw huge inferences from these events. But your point is a good one. For people who are interested, go on the website. All of this information is available. It has been distilled to protect confidentiality, and staggering, some of it. Yeah. So, but it can help you just think about, oh, you know, maybe I need to have my nurse call Mr. Jones, who's 82 years old and a recent widow and, you know, lives way out Mullen, and yeah, so. Great. Well, thank you all for coming.